All right, so we're going to go ahead and get started so we can get to all the information in today's webinar. Thank you everyone for joining us today. My name is Elena Kidd and I'm a program director with the University of Alabama at Birmingham School of Public Health's Office of Public Health Practice. And I'm very excited to welcome you to today's webinar, Public Perceptions and Preferences for Antibiotics, Considerations for Health Communication, featuring Dr. Alistair Thorpe from the University College of London. This webinar is made possible by the Alabama Regional Center for Infection Prevention and Control Training and Technical Assistance, or ARC-IPC. The ARC-IPC was established to meet the consultation and support service needs surrounding infection prevention and control throughout the state of Alabama. The center is a collaborative effort of the Alabama Department of Public Health's Infectious Disease and Outbreaks Division and the University of Alabama at Birmingham. The ARC-IPC provides training and technical assistance to infection prevention and control and public health professionals in areas needed to detect, respond to, control, and prevent infectious disease outbreaks. You can learn more about the center, view and listen to past webinars, podcasts, sign up for a newsletter, request training and technical assistance, and view infection prevention and control resources at our website, uab.edu/ARC-IPC. You can also email us at ARC-IPC or ARC-IPC@uab.edu with any questions. We would like to thank our co-sponsors for today's webinar, the Deep South Center for Occupational Health and Safety and the Region 4 Public Health Training Center. You can learn more about their programs and their centers as a whole on their websites listed on the slide. We would like to let you know about our upcoming webinar, Theories of Behavioral Change Applied to Politicized Health Behaviors, Predicting Intentions to Receive a COVID-19 Vaccine, on January 23rd with Dr. Greg Pavella and Dr. Tamika Smith from the UAB School of Public Health. Once available, more information about this webinar will be placed on our website and announced through an e-blast from the ARC-IPC. This webinar will also be sponsored and co-sponsored by the ARC-IPC and co-sponsored by the Region 4 Public Health Training Center and the Deep South Center for Occupational Health and Safety. Registration information will be available soon. Continuing education credits have been approved for nurses by the Deep South Center for Occupational Health and Safety for this program. In order to receive credit for this training, you must register for the training, watch the entire program, complete the evaluation after the program, and upon completion of the evaluation, you'll be redirected to the Alabama Nursing CEU request form, which you also need to complete. CEUs will be awarded by the Deep South Center for Occupational Health and Safety. You do not have to submit it directly to the Alabama Board of Nursing. And please allow 2 weeks for those to be appearing on the Alabama Board of Nursing dashboard. CEUs for this program will expire on December 14th, 2023. If you experience any issues, please email arcipc@uab.edu and we'll place this email in the chat box as well. If you are located outside of the state of Alabama and would like a certificate of participation, you can also email arcipc@uab.edu. And finally, it is my pleasure to introduce our speaker. Dr. Thorpe received his PhD in psychology in 2019 from the University of Essex for his work on the effect of different health communication methods at reducing clinically inappropriate antibiotic use in primary care. He then spent 2.5 years as a postdoctoral research fellow in the Department of Population Health Science at the University of Utah before joining the Department of Applied Health Research at University College London in November as a research fellow. Dr. Thorpe's research is targeted at identifying the key factors underlying decision-making processes of patients and medical practitioners in order to better understand how people estimate, judge, and make choices about important health decisions. From these findings, he aims to develop and test health interventions such as communication strategies and decision supports. So without further ado, it is my pleasure to turn things over to Dr. Thorpe. And thank you so much for being here.
So I just want to start off by first of all just saying thank you very much for that lovely introduction, Elena, and thank you all for the opportunity to talk with you all today. Just to build a little bit of my background and based on what Elena just previously mentioned, yeah, really in my research is embedded in 3 key principles of understanding how people make important health-related decisions, how we can better communicate health information, and how we can use that information also to develop decisional and educational support for patients who need it. And I've been very fortunate in my career to date to have applied my research in a number of contexts, including antibiotic use, public health response to crisis such as the COVID-19, as well as online health search, helping high-risk populations make critical healthcare decisions, and understanding and communicating predicted risks and randomized controlled trial evidence of treatment effects, which, if anyone's interested, I'd love to come back and talk with you all again and more about this at some point. For today, I'm going to talk to you about some of my work looking into public perceptions and preferences for antibiotics, and really some of the considerations and next steps for health communication in this area. So just to start off, if anyone is not fully up to date with what antibiotic resistance is and why we should care about it, really the rise of antibiotic resistance is one of the most serious threats to public health, and failure to effectively combat increasing levels of global antibiotic resistance can have catastrophic consequences. And what has been labeled as a post-antibiotic era in which bacterial infections and complications from routine medical procedures cannot be treated is becoming a very real possibility. And as you can see from the image, unless drastic action is taken, it's estimated that by 2050, antibiotic-resistant infections will be responsible for around 10 million deaths every year. And although antibiotic resistance is a naturally occurring phenomena, human activity substantially accelerates this process. And this includes a range of different ways that this happens, and including the excessive use of antibiotics in agriculture, economic and regulatory obstacles to the development of new and safer antibiotics. And what we'll focus on today is the suboptimal use of antibiotics in healthcare situations. Within the healthcare scenario, my research primarily focuses on patient and public use, patient and public behavior regarding antibiotics. And I want to focus on this area not only because I think that helping people understand their health and the benefits and risks of available treatments is important in its own right, but also because evidence has shown that there are a number of pathways to primarily which public patient behavior can contribute to increased inappropriate use of antibiotics. And so the first pathway is through directly obtaining and inappropriately using, sharing, or disposing of antibiotics. And there's a number of studies which have shown that these types of behaviors are prevalent throughout society. And while the improper use of antibiotics in this way may be more prevalent in lower middle income countries, just due to the increased availability of antibiotics, it's certainly not limited to those. And I think a nice example of that is about a few months ago, the Health Secretary of the United Kingdom, this news article reported that they had admitted that they are illegally sharing antibiotics with their friends and family without a prescription. And the second pathway, which we'll speak a bit more about today, relates to patient interactions with clinicians and their influence on the prescriber's behavior. And there's a wide body of evidence from general medical settings which indicates that patient behaviors during interactions with clinicians can have a substantial influence on the decisions to withhold or provide treatment. And for antibiotics, this is very much the case. And there's a series of observational studies, which I've noted here, which have previously indicated that patient expectations for antibiotics are an important predictor of antibiotic prescribing above and beyond clinical factors. But it wasn't until 2017 when a study was published in Health Psychology, which really provided a really nice causal test of this hypothesis. And just to quickly talk you through the study, in this study, the authors recruited 131 primary care physicians to take part in a study where they saw a descriptive vignette of a patient who was a new patient consulting at their practice with symptoms of a viral ear infection. And the physicians in the study were split to a high or low expectation group. In the low expectation group, the patient only described their symptoms. In the high expectation group, the patient indicated that they really wanted antibiotics to get better quicker because they had an important event coming up. What the authors found, as you can see from the graphs in the light gray bars, the likelihood of prescribing substantially increased when the patient expectations were explicit in the scenario, even though the perception of whether the infection was actually viral or bacterial did not change. So this work provided some really nice causal evidence to support prior studies that indicating that inappropriate patient expectations can lead directly to overprescribing of antibiotics. But it also raised the question of what is driving these expectations in patients. And when we look at antibiotic-related health communications, there's a clear prevailing assumption that inappropriate antibiotic expectations are driven by a lack of knowledge. And we see this quite clearly reflected in the development and distribution of information-based health messages by governments and health organizations around the world. And I have here just some examples from the UK and the US, the CDC and the NHS. And you can see that these tend to follow a similar pattern, and they describe the difference between viruses and bacteria. They aim to provide clarity that antibiotics are only effective against bacteria, and some mention about the costs and risks of inappropriate use. And although we know from a number of population level surveys and studies that across the world that people do have misconceptions and misunderstandings about antibiotics, the findings from studies assessing these public focused education-based interventions have found them to be largely underwhelming. And this is across all three domains in terms of modifying public knowledge, improving behaviors, as well as affecting prescription rates in the areas in which they're implemented. So given these findings, we really wanted to look into two questions. Firstly, we wanted to really understand what extent does information provision reduce clinically inappropriate expectations for antibiotics? And the second question we were interested in is, does the type of information that's provided matter? And we set out to answer this in a study that was published last year. And I just want to note that throughout, as we mentioned studies, if you see these three blue, red, and yellow badges, they just mean that the study was pre-registered online prior to being conducted, and that the data and materials are openly available if anyone would like to look at them. And so in this study, we conducted an experimental study where we asked otherwise healthy participants to imagine symptoms of a respiratory tract infection that caused them to visit their doctor. And we then randomized participants to one of four conditions. We had a control condition where participants didn't get any other information, and they then made their decisions and expectations based on whatever prior knowledge they had. One group of individuals was given antibiotic information only, told that antibiotics would not be effective and may cause some harms. Another group was given only viral information, that the respiratory tract infection was caused by a virus. And then we had what we called the complete information group, which received a combination of information that the antibiotics don't help and could be harmful, as well as the viral etiology of the infection. And just before I go through the results here, we then asked participants to, in this situation, respond about how much they would expect to take antibiotics. And just to orient you to this graph, the black horizontal bold lines for each of the groups represents the mean, with the box borders as the 95% confidence intervals, and the circles within each density distribution represent the individual data points. And we can see from the graph that over on the far left, the control group, they had the highest expectations of antibiotics. They weren't extremely high, but it was higher than all of the other groups. We can then also see that the group who received only antibiotic information, there was a decrease in their expectations for antibiotics, whereas if you compare that to the group that only received information about the viral etiology of the illness, there was not the same reduction. And over in the complete information condition, remember this was the group that received both information about the antibiotics not being effective, it could be harmful, and the viral origin of the illness, we saw the biggest reduction in the expectations for antibiotics. However, what really stood out to us was the fact that there were a number of individuals who were in this, what we called the complete information group, who still had reasonably high expectations of antibiotics. And so in a couple of follow-up studies, we wanted to really dig a little bit further. So we did a couple of vignette-based experiment studies to follow up on this and address some of the potential methodological concerns that may have led to this result that we thought might explain it. So the first one, in addition to expanding and diversifying our participant pool, we also expanded into another illness context. So we conducted one study in, again, a respiratory tract throat infection, the common cold, and we also did an ear infection of acute otitis media. We also then looked at, again, in this study, we only looked at incomplete versus complete information, as we saw that was the biggest reduction. But one thing we thought was that potentially in the prior study, we just said that that it was considered by the general practitioner, the primary care physician, that the infection was caused by a virus. So in this one, we wanted to reduce the uncertainty, which we thought might have led to some people having high expectations for antibiotics. And we added in that the viral nature of the infection was confirmed in this scenario by a blood test. We also felt that potentially asking people their expectations for antibiotics, some participants might have interpreted that as the expectation that they might receive antibiotics rather than that they expect them to help. So in these studies, we changed the dependent variable to be whether they would decide to take antibiotics or not, to really drill down and get into whether these people wanted to take antibiotics or not whether they thought they might get them. And so in this study, we pretty much replicated the results of the prior work, where we found that without the information in the gray bars, we saw that around 40% of people wanted antibiotics, both in the common cold respiratory throat infection scenario and the ear infection scenario. But when the complete information was provided that antibiotics would not be effective and that wanting antibiotics in this situation would be clinically inappropriate, we saw a decrease in both conditions of about 30%. However, despite this positive result that providing information did in fact have a drastic effect on reducing antibiotic expectations, we still noted that around 10 to 15% of people wanted to take antibiotics in these scenarios. And these studies were really important to us because there's a lot of talk about the insufficient information hypothesis and providing information not being enough, but we found that information provision and the type that is readily provided does actually reduce inappropriate expectations. So there is a benefit to providing this information, and it is having somewhat of a desired effect. However, it is clear that it does not completely reduce inappropriate expectations, and it does not do so for everyone. And what we found, like we said, was around 10 to 15% of people still want antibiotics, despite having complete information that they won't work and may in fact be harmful to take. So leading on from this, the question we immediately asked ourselves was, well, why do some people want antibiotics, even after being told that they won't help and may be harmful? And what we looked to try and answer this question was we looked to the literature on the influence of cognitive factors in a range of other medical decision-making scenarios. And so in a follow-up study, we looked at 4 specific cognitive factors which have been shown to affect decision-making both generally in life and also in medical situations. And the first cognitive bias we considered was the action bias. And just as a bit of background of this one, one of the seminal studies of this was conducted actually in sport, where the authors interviewed some goalkeepers who were trying to save penalties, and they found that the keepers would dive one way or the other. And they observed that the actually most effective strategy would be to stay in the middle, and they would save more penalties in the long term. And when they provided this information to the goalkeepers still maintained that they would prefer to keep their strategy of diving one way or another, with their response being that they would prefer to do something, even if it was less effective, than to do nothing, which they termed inaction versus action. And that's what the action bias basically is. It's a preference to act, even when it yields suboptimal outcomes, to an opposite action of inaction. So this was something that we felt, and it has also been shown in clinical settings, medical scenarios, of people's preference to engage in cancer screening when it offers no benefits. So this was something we thought may, in fact, be playing a role in people's desire to take antibiotics, even when they have complete information. We also looked at the role of social norms, which is a bit more straightforward, just the idea that people want to do what other people do. So even though you may have the information antibiotics won't help, if you believe that people like you or people who are important to you are taking antibiotics, that will motivate your decision-making in that situation. And we also wanted to look at the role of source discrediting, like who's the information coming from and how do people feel about who's giving them the information. And this is based on a wide body of evidence showing that when people have a prior belief or strong intention, if they receive information that conflicts with this prior intention or belief, one strategy that people sometimes engage in is to discredit the source of information. Say, oh, they're not trustworthy or they're not competent. And so even though they've given me this information, I'm not going to act on it and I'm not going to believe it. And the final one was information neglect. And again, this is another processing-based cognitive factor, which is just the idea that people will avoid information if it requires them to make a big change or may have a negative emotional effect. And in medical situations, this has been documented several times, such as HIV patients refusing to follow up and observe their test results because they know it may contain information that they might find emotionally distressing or may require them to make a substantive change to their lifestyle. And so what we did was we followed up with the individuals in the previous study who had been given complete information. So they were given all the information that they would need to understand that antibiotics were clinically unwarranted and would be harmful, and who still decided that they wanted to take antibiotics. And we asked them to their agreement with a number of statements regarding these biases. So for example, the action bias was whether they preferred to just do something than nothing in that situation, as well as the social norm, source discrediting, and information neglect items. And what we found was that overall, all of these biases were positively associated with the decision to take antibiotics in a situation of where there's complete information that antibiotics won't help and will be harmful. But that the action bias was clearly across, we did it across both studies, the common cold and the ear infection vignette, that the action bias was the strongest predictor of decision to take antibiotics in these situations, regardless of how we measured it. We used a single item and a multi-item measure. And so the next step we wanted to do was, okay, so we'd identified that the action bias was the strongest predictor among the other cognitive factors, and we wanted to see, was there something we can do in terms of health communication that might help address the action bias and reduce the impact it's having on people's decision making in these contexts. And so what we did was we did a follow-up experiment where we interviewed a number of people and sent out a questionnaire asking people to rate this, treatment options as action or inaction. And what we saw straight off the bat was clear that the options of taking antibiotics were clearly seen by 97 to 99% of people rated that as an action that they felt, that treatment option. Whereas when we asked them about the option of resting and not taking antibiotics, the highest we could get it was to 50% of people saying it felt like an action. And this was through wording, as you can see, saying, fight the infection by taking 3 days rest, taking 3 days to overcome the infection. So we tried a number of different wording styles to try and make rest seem like an action, but that we couldn't get more than 60% of people who felt it was an action. So it was predominantly viewed as inaction. We eventually did get to a point where we could get up to low 80% of people saying that they did perceive rest as an action. And the only way we could do that, as you can see from the bottom of the table here, was by pairing rest with another action, which in this case was to take painkillers. So this was the best we could do in terms of the framing of rest as an action. So we knew that the standard framing, we had take antibiotics, which was perceived as an action, and we had rest without antibiotics, which was perceived as inaction. So we ran a follow-up experiment where we randomized, instead of changing any information in the vignette, we just changed the framing of the options. So we had the standard framing, and then we also introduced the active framing where we added in take painkillers to the rest option, as we saw that that was also treated as an action. We were hoping that by having two action-based options, that might reduce the idea that people will go for the antibiotics, as that option will not be seen as an action compared to inaction, but action compared to action. And the antibiotics would also have the costs associated with it. And so we ran this follow-up study with about 700 people. And we again saw that when people were given, and all of these people were given complete information about antibiotics being unhelpful and the viral etiology of the illness. And we again saw that there was a massive reduction, about almost 90% of people preferred to rest, but we still had a resistant 12 to 9% of people in both conditions who wanted to take antibiotics, and there was no difference between groups. So these studies were still very enlightening for us. It was really great to get the evidence that inappropriate antibiotic expectations were strongly associated with a range of known cognitive biases, which gives us a really strong foothold in knowing what to target as we move forwards with health communication efforts. Particularly important to realize that the action bias was the most prominent of these biases in affecting the decision making, but that proved difficult to address using sort of subtle health communication manipulations, nudges in that sort of sense. So I think it's something where we need to take a step back and think, okay, health communications may not be sufficient to address these kind of strong biases of doing something in these situations, and we may need to look at alternative approaches. However, we also didn't want to just put all our eggs in one basket, looking at just the action bias. As we said, all four of the biases we looked at were predicted decision to take antibiotics under complete information. And we also nudged along our way at the next area that we wanted to look at, which was the trust in doctors and the source credibility. And we were nudged in this way because around the time we were working on this, there was a campaign that came out in the UK, which was heavily focused on taking your doctor's advice and trusting your doctors, as you can see here. It had a very catchy jingle, which I would recommend checking out and seeing if it stays in your head for a while. It did with me. I was singing it in the car every time I was driving anywhere. And so we wanted to really look at the role of trust in people's expectations for antibiotics and how information might affect that. So we subtly manipulated our design where we, again, had the vignette with no information or complete information. But before that, we asked people to report how much they trust their physician. We asked them to think about the physician they see most often or that is most memorable to them. What we found initially was contrary to what we predicted. We actually found that there was a positive correlation between trust in physicians and expectations for antibiotics. So the more that people reported that they trust their physicians, the higher the likelihood that they were reporting that they would expect antibiotics in a situation where it was inappropriate. And so what we did was we dug a little bit further, and we saw that this depended heavily on the information condition that they were assigned to. So you can see above the group who were in blue with the blue circles, the higher bar has the positive relationship. This was really driving that relationship. And it was the individuals who didn't receive any information about antibiotics. That was where the positive relationship. Whereas when there was full information, when people were given information about antibiotics being ineffective and the viral nature of the illness, there we see the negative relationship that we really are hoping for, that, greater trust facilitates the information provision, and people with higher trust have lower expectations of antibiotics. And so we then wanted to look at, okay, we see that there is this relationship with trust in physicians, information provision, and expectation for antibiotics. Are there any ways we can manipulate trust to enhance the effect during this stage? And so what we did in the follow-up study was we again randomized people to a control group, which was just their prior knowledge or complete information. But we also had a low trust manipulation, where we manipulated how the physician in the scenario behaved. And so the low trust was based on manipulating low warmth and low competence. And these were done by, the person didn't greet you the physician didn't greet the patient when they came in, didn't make eye contact, was a little bit unprepared, and had to look for a few things during the consultation, and made a small mistake on the respiratory exam. And then we compared this with, again, the control and full information condition in a high trust, where it was just the opposite, greeting with a smile, face-to-face, talking throughout, and being well prepared and conducting an efficient exam. All of this low trust and high trust we tested in pre-test to make sure that they were working effectively as we'd hoped. And what we found, so you can see on the left-hand side of the graph, we've got the low trust condition and then whether they had information or not, and the high trust on the right. And what we see is that the low trust condition who had no information, we see the highest expectations of antibiotics that we'd seen so far. So that was really clear evidence that, low trust, manipulating low trust to make people not trust the doctor and have low perceptions of the warmth and competence of the physician they're interacting with, and not getting the relevant information they need, led to really high expectations of antibiotics when it was inappropriate. We again replicate the effect that providing complete information reduced the reduced expectations of antibiotics, regardless of whether there was high trust or low trust. And we did see a compounding of this effect in a beneficial way with the high trust and complete information condition on the far right-hand side, although this wasn't as drastic as we had hoped originally. And these studies were really important. I think they were really important in establishing that the relationship between trusting clinicians and lowering appropriate expectations is really dependent on information provision. And without that information provision, this can actually backfire. If you just try and enhance trust without providing that information, it can actually lead to higher rates of inappropriate expectations for antibiotics among the public. So from a public health messaging perspective, that's really important, I think, to remain vigilant about that. Whenever we're enhancing trust, we are providing the relevant information at the same time. From a more interactive perspective, when talking with patients and having conversations with them in primary care facilities or any other tertiary care facilities that it may be, enhancing trust through very subtle warmth and competence manipulations, being friendly, being well prepared, can facilitate the provision of antibiotic information, but doesn't seem to be the massive effect that we might hope for. And now I want to talk a little about some more recent research we've been looking at, which has been more regarding how we communicate about more abstract topics. And this has been brought on primarily by recent increase in the awareness of antibiotic resistance, but evidence showing that awareness of antibiotic resistance is not translating into increased changes in behaviors or attitudes. That people are aware of what antibiotic resistance is, they're seeing more and more of it, but they feel like it doesn't affect them, or it's something that is distant to them either geographically or temporally, or something that's just very abstract and hard for them to figure out. So this was a study we published earlier this year, and we again took a vignette-based approach and experiment. We kept our standard of providing complete information in one condition, and we changed slightly our control condition to provide some information, but it was just unrelated. So it was information about how important the costs and benefits of having your own garden and growing your own fruits and vegetables. But then we wanted to look about how we communicate about the potential costs of antibiotic resistance. And so the first thing we looked at was making the cost self-relevant, as prior research has shown that people make risk perceptions increase and behavior intentions are more likely when people feel like something is going to affect them. So we had a description of the growing rates of antibiotic resistance, and then we had a small section, which I've given a snapshot here, of just explaining that what it means for you, that people might be in a situation that antibiotics won't work for them and they may get an illness that they can't recover from. And then we also drew upon some prior work, primarily from the field of vaccine health communication, which has shown that in some situations, using narrative stories or very sort of salient stories about other patients and patient profiles can also have a very dramatic effect. And so from the Infectious Disease Society website, we took a story that they had of a young girl who had a really tough time fighting a number of antibiotic-resistant infections, and a very emotive story. And we used that as an example of, can we use stories about others to communicate the costs of antibiotic resistance? And we conducted this, we did 2 studies and varied the context, but the results are very similar across both studies. So I just present one here. And again, we can see on the left-hand side is the control gardening condition, and then the 3 intervention conditions we had. And what we found was that all of the interventions decreased expectations relative to the control condition, but that what we didn't expect was that the narrative and other cost condition, the story of the small girl, was the smallest effect compared to simply providing information about when antibiotics should be used and shouldn't be used, and the making this cost self-relevant. And from that, this is something I want to talk about. I think it's really interesting and something that we haven't published, but we conducted around the same time, and I think gives another perspective on how we communicate about the costs of antibiotic resistance, whether they're self-relevant or talking about others. And this is a film that came out in 2016 called Catch, which I recommend watching. And it's a short dramatical story about this post-apocalyptic antibiotic future, which may happen if antibiotics stop working and there are a rise of bacterial superbugs which cannot be treated. And it's a very emotive story about a family who are going through a quarantine period, and they're running out of supplies, and you can see the father there is dressed in PPE trying to interact with his daughter. And it tugs on all the right emotional heartstrings. You know, there's pictures of the daughter drawing about the family who are not there anymore because of the situation, and you know, it's revealed that this is drawn on the box of antibiotics which is running out, and it's a very emotive story. And so what we did was we randomized people to either watch this very emotive, very dramatic story about antibiotics, or to see another future film which was completely unrelated to healthcare but still set in the future to be similar in that regard. And what we found was that there was a dramatic effect on the antibiotic expectations among those who saw the interventions. On the right-hand side, the intervention film, we see there's a massive reduction in the expectations for antibiotics, and the likelihood that they would request antibiotics in a situation where we described again a viral situation, a viral illness that they were experiencing with their doctor. And so this was really, again, something that we weren't expecting, such a dramatic increase in the effect to come out of this. And so I think these studies were really important, were great for us to show that there's an approach now where lots of health organizations and governments are trying to really communicate about the growing costs of antibiotic resistance and the drastic need to tackle it. And we've shown that vivid representation of the antibiotic-related costs can be an effective messaging strategy, and this supports prior work. Another study came from Roop and their colleagues showing that describing very sort of fear-based messaging can be effective in helping people realize that they would be less likely to expect and request antibiotics for viral infections, and other work showing that, again, people who don't perceive antibiotic resistance to be something that affects them are much less likely to change their behavior or revise their expectations for antibiotics when inappropriate. I think another reason why I brought up the second study, even though it's not published, but some work we did on the video, was that I think there still is a lot of further work we need to do on how and when we frame antibiotic related costs as self-relevant versus regarding others. So for example, in the paper we published, we saw that the smallest effect was from the patient story from the Infectious Disease Society, which had the smallest effect, whereas compared to the video, we saw that a dramatic effect, which we weren't expecting. And so I think that's just something we need to consider and do a lot more work on when and where do we communicate about when the cost, when do we want people to think about how it might affect themselves, and when do we want people to think about how it might affect others, and what mediums do we use. And another thing that also came out through the video was the impact that the current COVID-19 pandemic has had on messaging. So those studies were all conducted prior to the COVID-19 pandemic. And I remember that at the time, some of the feedback that we were getting from the people who were watching the video was that it felt very unrealistic. It felt a bit extreme, you know, the fact that but it was all things that people have been going through over the last 2 or 3 years. Dressing up in PPE, isolating from family members within your own home, and shortages of critical resources. So I think given the impact of the COVID-19 pandemic, there's a lot that we need to think about how that might have affected people's attitudes towards global health crisis generally. Are people burnt out? Are people more willing to engage in preventative behaviors, or has there been, and how can we override the sort of polarizing political effects that we've seen with COVID-19 messaging, and make sure we don't repeat any mistakes that we have done previously. And for the last 5 minutes, I just want to talk about some future directions that I think are really important for us to consider as we move forwards, and that we have planned to work on as we move forward, which I think are areas where health communication really needs a helping hand in understanding how people are responding and interpreting the evidence and the new directions that we're taking in these regards, course durations, allergies, and social norms. So regarding course duration, you know, there's widespread evidence for a long time. Lots of health communications have included information about always taking a prescription, even if you feel better. And this has been a long-standing messages of lots of global health communications in different countries. And in the last 10 years or so, there's been a change in the framing that new evidence has come to light that this may not be the best approach, and that shorter courses may in fact be as effective and less likely to promote the development of antibiotic resistance. And this really represents a change in dogma. And as you can see here, a quote from the article in JAMA Internal Medicine, which is promoting actually that patients should be told not to complete their full course and should discuss with their doctor when to change. I think this is a really important area for us to really work hard in how we communicate about this, because as we've seen, again, using the example of the COVID-19 pandemic, changes in guidance, when they're not communicated effectively or seem to be communicated ineffectively, can have really dramatic effects. And the example here of the pause of the Johnson & Johnson vaccine, which is tracked by the Economist, showing the change in the perceptions of the safety, both pre and post the pause. So this is an area where I think it's really important. We've done some work looking at how to communicate uncertainty in general situations, particularly in the COVID-19 pandemic. We looked at how we can use an uncertainty normalizing approach to prepare people for that science isn't always straightforward. There's not one right answer, and that this can help alleviate some of the negative consequences. But there's a study I really want to talk about, which was conducted by Gretton and colleagues. And the reason I like this one is that they particularly looked at how a forewarning intervention that uses the same approach, normalizing uncertainty and changing evidence, but they looked at how this affects consistent and inconsistent messaging. So the consistent messaging was that it regarded masks. They used a couple of different examples, but I've got the one here of masks, where the consistent messaging explained that you've always been told to wear masks, masks can help, and masks are still recommended. And then in the inconsistent messages, they acknowledged that, you know, previously it was advised against wearing masks, and now there's a change in guidance where we are recommending it. And the results from this study were really interesting. And you can see here in the condition where participants didn't read that forewarning information, when they were given inconsistent information, there was a reduction in a number of perceptions important for health-related outcomes. So people had reduced trust in the expertise of public health authorities, reduced intentions to get a COVID-19 vaccine. Whereas when the forewarning intervention was employed prior to them reading whether it was inconsistent, consistent messaging, these effects were completely removed, and there was no difference based on. So I think that's something where we can really take take hope in communicating future changes about antibiotic use and when what's appropriate, but something that we need to first establish is effective when communicating about changes in antibiotic guidance, such as course duration. Another area which we're working on and really thinking about deeply is about how we communicate about antibiotic allergies and delabeling process. So we know that now that there's strong evidence that 9 out of 10 individuals who think they have a penicillin allergy are no longer truly allergic and can be safely delabeled following a test. And we know that the inappropriate use of broad spectrum antibiotics in these individuals who may not have an antibiotic allergy has a number of important consequences, such as promoting antibiotic resistance, both population level and increasing the risk of the individual when developing severe infections such as Clostridium difficile and other types, and also increasing the short-term costs such as adverse side effects, increased hospital stays. And so there's a really, really strong push to effectively delabel antibiotic allergies when it's safe to. However, there's very little understanding of how people, the public, understand this new process and what their feelings are towards it. There's one recent focus group study which has explored some of the potential issues to removing an incorrect penicillin allergy, and they've highlighted here that really this revolves around gaining the confidence of patients and really highlighting the importance of communicating why we are delabeling them. And I think what we need to do is really work to develop a number of strategies that we have, some communication strategies to really effectively communicate this information. And on the last thing I want to talk about, which is just very briefly, well, we touched on it in the earlier talk about the cognitive factors that were influencing decisions, and one of the closely behind the action bias was the social norm perception, the idea that people's friends and families would take antibiotics and so they wanted to as well. And I just have a couple of examples here from UK-based health messaging, where you can see that the framing of the messages is around the highlighting the number of people who are engaging in the behavior we don't want them to do. So you can see that it's saying 1 in 3 people got an antibiotic prescription that they shouldn't have. 38% of people expect an antibiotic when they shouldn't. And this is, to me, a way of framing the social norm, which is not positively reinforcing that we shouldn't be doing this. And if people already have the perception that they're going to do whatever most people are doing, is probably not the best way to go about this. So this is another area where I just think is going to be really important for us moving forwards, that we try to communicate better and we understand how we can reach different groups, especially given the different unique experiences and idiosyncrasies of different populations within society and their own experiences. And so that's something that we're also going to work on moving forwards. And across all 3 of these future directions, I hope to have something soon to share with you, which would be really exciting. And lastly, I'd just like to close by thanking throughout my career, I've been very lucky to have a great support through mentorship and supervisors. They go back to the University of Essex, where I was in the Department of Psychology, working with Miroslav Sirota, Marie Juancic, and Sheena Orbell, who were very supportive in my time as a PhD student there, and really helped ground me in understanding getting the critical skills to conduct this research. And then when I moved to the University of Utah, working with Angela Fagerlin and Valerie Vaughan, who again were incredibly supportive and gave brilliant guidance along the way. And all of whom were very patient with me as I've been working on this stuff. And Rachel Lee, who has recently joined me as a mentor and been also great in guidance and helpful thinking of new studies and new approaches to health communication in areas where we need to really do better moving forwards. And I would like to wrap up there and say thank you very much for listening to me. And if you have any questions and would love to keep in touch and answer any questions you have, please feel free to.
And thank you so much, Dr. Thorpe. That was an excellent presentation and all very interesting information, and definitely gives us a lot to take into consideration when trying to build relationships with patients and also communicate about antibiotic and antibiotic use. So we did have one question that came in through the Q&A. One question kind of going back to earlier in your presentation is, how were you able to parse out the difference in action bias and information neglect? The motivations seem, or they could be, very similar.
Yeah, that's a really great point. So we tried to design the questions to be as independent as possible, and we obviously looked at the psychometric properties, which showed that there wasn't sort of intercorrelation between the measures. It's true that then we don't think that all of those things are mutually exclusive. So we don't think that there are some people who are motivated by an action bias and some people who are motivated by the social norm, but we just wanted to see which of those seem to have the strongest impact. So we definitely consider that these are definitely not mutually exclusive, and in fact probably support each other in some way. You have an action bias, so you're more likely to ignore the information as well. But it's about which of those we want to address head on first. But again, yeah, we were just looking at which seemed to be the strongest predictor rather than the unique predictor. And that was how we initially went to look at addressing the health communication measure. But it's a very good point that potentially looking at health communication strategies which are broader and address more than one issue at a time could also be a likely way to be more effective in communicating this information.
All right, thank you so much for providing us some more information. And another question came in. Were there any notable trends in the individuals who still wanted antibiotics after receiving complete information, such as demographics or educational background?
That's a really good question. That's something that we're looking at in the next step, like we said, looking at tailoring to different unique populations. These initial set of studies were not designed to look at that in terms of being naturally representative. We were trying to get large samples, but we weren't looking specifically at demographics. So that's not something we've really explored yet, but something that is the next step of saying, okay, can we tailor these messages to people rather than just using this broad blanket approach. But we were really trying to look at originally just that blanket approach of, okay, the messaging to everyone, what are the cognitive factors underlying this rather than the patient level characteristics of their sort of demographics and individual differences. But that's something, yeah, we're going to look at moving forwards.
Thank you so much. One more, how can you overcome family influences? Can age and education help? And also, thank you.
It's tough, yeah. Overcoming family influences is like we sort of social norms, and this is across life, right? They are what have a massive influence on what people do and what they think. The social norm influences, and my perspective is that we're not ever going to directly overcome messaging that tries to tell you something different, that what your parents tell you or your friends tell you is not going to work. But the idea is that if we provide, and as we see from other effective health communication campaigns such as smoking, the idea that consistent messaging that can change the kind of social perception of the appropriate behavior, and you sort of see over time people changing their behavior, and you see from the people around you what they're doing and what they're hearing. That's the way to kind of really instill that long-term change in behavior. But I think from a health community, like directly going again, like trying to communicate different values to what family and friends are is not going to be an effective strategy.
And I noticed you're probably drawing a lot of simulators between the COVID vaccine and antibiotic use between your research, right?
Yeah, I mean, it's all of this research, just to make them clear that everything here was done pre-pandemic. So it's something that we're also considering if we need to just do everything again, just to see what's changed, because of just how widespread the pandemic and how much it affected everyone. And like we said, like there was just new levels of people's interaction with healthcare systems and healthcare communication. So that's something that we really need to consider moving forwards. And I really do think there's a potential for leveraging that as a force for good in terms of how we communicate. A lot of, you don't want to say lessons learned until you actually show that you've learned them, but there's a lot of stuff that we can build on and identify that we could potentially do better. And that I think really serves us for good stead as we try and communicate. We still, the positive spin of the antibiotic resistance element is that there is still more time. COVID it came on suddenly and we had to react in that moment. Whereas we've got, we as long as we targeted, coordinated efforts in developing these arsenals of communication strategies and ways of, like you said, very great words, building trust with patients and engaging with them where they're at, that's a way we can move forwards with this and hopefully really help avoid a lot of unnecessary an unnecessary impact of the antibiotic resistance crisis.
Sounds like you have a lot of research up ahead and a lot of work to do, and you'll stay very busy. Well, we want to thank you very much for taking time out of your schedule to talk with us. And we thank you for your time and your presentation, all very useful, interesting, excellently presented information. So thank you very much. And with that, we will go ahead and close out the webinar. And if you have any questions, feel free to email us at arcipc@uab.edu. And otherwise, please look forward to the link with the recording, the slides, and the evaluation to be sent within the next week. So thank you very much, everyone, and we will see you next time.